it can be sent very easily from most diagnostic labs, and it's still extremely useful. However, it does have some ambiguities, especially if it's only mildly elevated. And I know a lot of us have experienced this in our practices where we see a patient, we're not really sure if there's a neuromuscular disorder going on, and the CK is, say, 300 or so. And that's always tricky. In Duchenne muscular dystrophy, it's typically not ambiguous. The CK level is typically above 1,000, and it can be 50 or 100,000. And the upper limit of normal hovers around 200 in most diagnostic labs. Now, genetic testing has become much more a frontline test for all forms of muscular dystrophy. For Duchenne in particular, 2/3 of cases are associated with deletions and duplications of one or more exons, and then 1/3 of cases are associated with smaller mutations. Single nucleotide variants is one kind, and then small insertions and deletions. So the genetic testing has become much more accessible, much more sophisticated, and it has become an indispensable tool for diagnosing these cases. However, the thing that is troubling about diagnosis, and this is something that is really sobering, is that when we look at the data over the past few decades, the age of diagnosis really hasn't changed for Duchenne muscular dystrophy. And you would think with the widespread availability of genetic testing, the greater knowledge and the new therapies, that it would come to mind more rapidly. But the average age of diagnosis is still 5 years of age. And that's unfortunate because there's a narrow window right now when the gene therapy is available to affected boys for Duchenne. So this is a problem. This is one of the reasons why it is important to think more carefully about newborn screening and why certain states have started to adopt it and why we hope that more will in the future. So if this happens not to be Duchenne muscular dystrophy, and I don't want to digress too much, but there are numerous forms of muscular dystrophy that are not Duchenne, and they can affect boys and girls. And unfortunately, there is this conception sometimes that it's primarily boys that get muscular dystrophy. It's actually not true. There are many females who also get muscular dystrophy. So having a female patient in your clinic shouldn't put muscular dystrophy out of mind as a consideration. It definitely occurs, and more often than I think sometimes we realize. So there are now dozens of genetic subtypes of muscular dystrophy that have been described, and this diagram shows you where some of the protein products operate. And the line across the middle shows the sarcolemma, which is the muscle fiber membrane. The top section of the diagram is the extracellular matrix, and then the bottom part is the inside of the muscle fiber. And you can see that proteins involved in muscular dystrophy are scattered throughout the muscle fiber and are sometimes outside the muscle fiber. And they create a complex architecture, which unfortunately is fairly fragile when you have a mutation in one of the encoding genes. So genetic testing panels for neuromuscular disorders now include over 100 genes. There is a lot of phenotypic overlap, meaning the clinical features can overlap among many of these genes. And the phenotype clues can help us interpret ambiguous or conflicting results. So physical exam is still very important. I do exams in clinic all the time, and I get valuable clues from them, despite all the really sophisticated diagnostic technology available now. Serum CK levels, as I mentioned, are valuable. Sometimes we still do muscle biopsies. And so even though muscle biopsies are not done as often in these children, sometimes you really are stuck with a difficult situation diagnostically, and it can be very useful in helping to resolve the matter. I think a lot of us who have been involved in sending genetic testing from our clinics have encountered these variants of unknown significance, and that really is quite frustrating. And I know that there are various research efforts around the country to try to find a better resolution to these, because when you see this on a genetic test report, it really leads to a lot of frustration and uncertainty. And sometimes you can find variants in more than one gene that also causes confusion. So let's get back to Duchenne muscular dystrophy. We had a little bit of a digression to other types of muscular dystrophy, and I won't go into those in detail due to the time constraints. And Duchenne is the most likely form that you would be seeing in your clinic. So there are 3 corticosteroids that are used now. The prednisone and deflazacort have been used for a long time, and vamorolone was just approved. And so now there are 3 types. They have different side effect profiles, so every patient's a little different. There's no one that's clearly the best corticosteroid at this time. I think it's important to think about what the patient's situation is like and the side effect profiles and what might be the best fit. So for antisense oligonucleotides, also known as exon skipping compounds, there are 4 approved by the FDA. And the dystrophin gene is really large and has 79 exons. And so there are various hotspot areas where you tend to have a lot of mutations. And by skipping some of these exons at the pre-mRNA stage, you can generate transcripts that are more intact. They'll be shorter than the ones that were originally encoded for, of course, but they'd be more functional and more stable than the ones that would be generated otherwise. And so these are important to consider in children who have Duchenne muscular dystrophy. The one caveat to keep in mind in terms of administration is these are only administered intravenously, and they have to be administered regularly on an indefinite basis. So that is a conversation that's important to have with a family. Are they able to bring their child in or arrange home infusions for an extended period of time without a clear endpoint? And so that's one thing that should be a thoughtful discussion with patients and their families. Gene therapy is a really exciting field right now. And there are many vehicles that exist. There are plasmid delivery systems, retroviruses, lentiviruses, adenoviruses, adeno-associated viruses. If you look at all in the literature, you'll see that there are all kinds of packages or vehicles where you can put genes or parts of genes to deliver into a patient that has a deficiency of one of these. All of these vehicles have strengths and limitations. Like with anything else, there's no perfect vehicle. Currently, the most popular virus or popular vehicle for gene therapy is what's called adeno-associated virus, or AAV. And you probably have seen AAV mentioned a lot. It is classified as a parvovirus in the virology world.